from the suprasternal notch to diaphragmatic hiatus. Then you are having the abdominal oesophagus. That is only about 1 centimeter from the diaphragmatic hiatus to the cardiac end of the stomach. See here you are seeing the oesophagus. This is upper thoracic, middle thoracic, lower thoracic. Then this part from cardiac is only 1 centimeter is the abdominal part. The relations of the cervical oesophagus is anteriorly it presents the two structures, mainly trachea and the recurrent laryngeal nerve. Posteriorly, the longest colli muscle and vertebral column. Actually, it is present in between trachea and vertebra. One on each side. If you go, first is the lobe of the thyroid and thoracic duct on the left side. This is relations of cervical oesophagus. Remember that. Relation of the thoracic oesophagus. Relation of thoracic oesophagus. Anteriorly, again the trachea and its bifurcation, the carina area. Later the left main bronchus, right pulmonary artery, pericardium with left atrium. These three structures, mainly right pulmonary artery, pericardium with left atrium, and left bronchus, they all come in the mediastinum, which is important. And these can also, when left atrium enlarges and compresses the oesophagus, then sometimes the patients may complain dysphagia. Later, the anti-relation is the diaphragm. Posterior relations are, you are seeing actually the vertebral body here, and you will see the thoracic duct posteriorly, and esophagus vein and the terminal parts of the hemiesophagus vein also will take part here. This is esophagus vein, and you are having a thoracic aorta mainly. This is what you call a descending part of the thoracic aorta, and some posterior intercostal arteries, particularly right posterior intercostal arteries, are related posteriorly to the thoracic part of the oesophagus. Right side, if you come, the right lung and pleura, esophagus vein and the right vagus are related. If you go for the left side of this thoracic part of the oesophagus, you find aortic arch, left subclavian artery, thoracic duct, and the left lung with pleura, left recurrent laryngeal artery. These are all the relations of the oesophagus, and the particularly thoracic part is very important, because the possibility of the extension of the disease from mediastinum into the oesophagus or from mediastinum to the external surface, pressure effects on the oesophagus will produce dysphagia. And in other words, from oesophagus, the disease may enter into the mediastinum. Coming to the abdominal oesophagus, this is half-inch long. Half-inch means it is about 1 centimeter. It enters into the abdomen through the oesophageal opening, that is hiatus, diaphragmatic hiatus, at the level of T10 vertebra. Already we discussed it goes up to the T11. What is the blood supply of this oesophagus? When coming to the cervical part, mainly the inferior thyroid artery, these are the inferior thyroid arteries, they give supply, either they arise directly from the subclavian artery, the left side, or it may arise from the thyrocervical trunk of subclavian artery. Like that, mainly the inferior thyroid supplies the upper thoracic part of the, or total cervical part of the oesophagus. Coming to the thoracic part, the esophageal branches of the descending thoracic artery and upper posterior intercostal arteries. These two will supply the thoracic part. Cervical part, inferior thyroid artery, may arise directly from subclavian in the left side or thyrocervical trunk, which is a branch of subclavian artery on the right side. Thoracic part, esophageal branches of the descending artery, descending thoracic artery, and upper posterior intercostal arteries also contribute partly for the thoracic part of the esophagus. Coming to the abdominal part, the left gastric branch of celiac trunk, left inferior phrenic artery, directly from the abdominal artery, this phrenic artery arises and supplies the abdominal part of the esophagus. Venous drainage corresponds to these arteries. In the neck, that is cervical part, drain into the inferior thyroid vein. In thoracic part, drain into esophagus or hemiesophagus system. In abdominal part, into left gastric vein. Lower part of the esophagus forms a site of portosystemic anastomosis. You all know whenever there is a disease of the liver, cirrhosis, there may be chance of developing varicosity in the lower 1/3 of the esophagus. This is what we learned from portosystemic anastomosis is the reason for that. Where there is anastomosis between left gastric vein and esophageal vein, a tributary of the hemiesophagus vein will be seen here. The lymphatic drainage, that also depending upon the cervical, thoracic, abdominal, it varies. When you consider about the cervical part, they drain into the lower deep cervical lymph nodes and paratracheal nodes. See, whenever you see upper part here, these are the paratracheal lymph nodes, and again they go into the deep cervical lymph nodes. Thoracic part, they drain into the posterior mediastinal lymph nodes. This is the thoracic part. These are the posterior mediastinal lymph nodes. Sometimes they have a small diaphragmatic lymph nodes also, and tracheobronchial lymph nodes also will drain from the thoracic part of the esophagus. The abdominal part of the esophagus, they drain mostly into the left gastric nodes only. These are the left gastric nodes where you will see particularly the abdominal part. Whenever there is a disease, they drain into the left gastric nodes. What is the nerve supply of this? The striated muscles in the upper half of the esophagus are supplied by it is a motor muscle, a recurrent laryngeal nerve, a branch of the vagus nerve. When you come to the smooth muscles in the lower half, it is supplied by the parasympathetic fibers, that is esophageal branches of the vagus nerve. Motor or striated muscle supplied by the branch of the vagus nerve through the recurrent laryngeal nerve. It is a motor. Smooth muscle, they are supplied by the parasympathetic fibers, esophageal branches of the vagus nerve. These fibers synapse in the ganglia of the submucosa. Ganglions present in the submucosa are called the Meissner's plexus, and other ganglia which are present between the longitudinal and also the circular layers is called the myenteric plexus, Meissner plexus and myenteric plexus. The applied anatomy in the myenteric plexus, when there is a defect, there is a dilatation of the lower end of the esophagus occurs, which we call, we'll see in the diseases there. The sympathetic fibers are derived from sympathetic trunk and come either directly from cardiac plexus or around the nerve plexus present blood vessels supplying the oesophagus. The sympathetic fibers are derived from the sympathetic trunk and come either directly from the cardiac plexus. You all know about cardiac plexus. Sometimes a plexus may be present around the blood vessels supplying the oesophagus. Esophageal mucosa is sensitive to heat and cold, but insensitive to touch. They can't feel the touch in the esophagus, but they are sensitive to heat and cold. The pain is very poorly localized when there is a foreign body or some disease corresponding to particular part of the esophagus. It cannot be localized because there it is insensitive. But you should know heat and cold. Sometimes a part is sensitive. Pain is poorly localized. Sometimes even though they can say that there is pain is there, it is only because of the muscle spasm rather than the stimulus produced over that area. We should know here about different constrictions. Particularly, this is very commonly asked. What are the constrictions present in the oesophagus? The first constriction, the narrowest part of its commencement is the cricopharyngeal sphincter. At the beginning, that is from 15 centimeters from the incisors, the esophagus starts. But there is one constriction called cricopharyngeal sphincter. After that, you are having another constriction. That is first constriction in the thoracic part. Is at the level of the arch of aorta. It is around 25 centimeters from the length. If you take from the incisors, around 22.52 or 25 centimeters, you find a constriction because of the arch of aorta, which gives a pressure over that. That is another constriction. Later, at the 27 centimeters from the incisors, that is at the T4 level, it is crossed by a left principal bronchus. Left principal bronchus is crossed at that level, and again you find another constriction at that particular level. Again at the level of the 37.5 or 40 centimeters, you are having the esophageal hiatus, where the esophagus passes through that, and again you get another constriction at the level. It corresponds at about the T10 here. See, one constriction 25, again 22, 5, 25, 27 to 27, again 37 or 40 centimeters R. You get again one constriction at the esophageal orifice, that is a cardiac orifice, there, which passes the esophagus through the hiatus present in the diaphragm. The pharyngoesophageal junction is the narrowest part of the alimentary canal, except for the vermiform appendix. What is the narrowest part of the gastrointestinal tract? Whenever asked, it is the pharyngoesophageal junction. Of course, there is appendix. It is an appendage which has a normal, smaller lumen than this cricopharyngeal sphincter, but it is not in the line of gastrointestinal tract. See, I told you after cricopharynx, you get constrictions. One is at the arch of aorta here. This will give a pressure, and you will see on the barium swallow the indentation. Then the left bronchus, which crosses this area, this is called the second one, and another one is the esophageal hiatus, where you will see the constriction. Coming to the physiology of the swallowing, the deglutition is the process where the propulsion of the bolus of the food from the oral cavity to the stomach. What is the deglutition? It is the process of propulsion of bolus of food from oral cavity to the stomach is called the deglutition. What happens in the normal deglutition? It is a smooth coordinated process which involves a complex series of voluntary and also involuntary neuromuscular contractions, and typically it is divided into three distinct phases. The normal deglutition is a smooth coordinated process which is having a both voluntary and involuntary neuromuscular contractions. What are the three phases? One is oral, it is a voluntary phase. Pharyngeal, both present, but mostly it is involuntary. Oesophageal is totally involuntary. Oral phase, again divided into oral preparatory phase, oral proper phase. When you discuss about the oral preparatory phase, this is a phase where the food is made it ready for swallowing by chewing and mixing it with saliva by the muscles of the lower jaw, that is jaw, and also the oral cavity, where the food is made ready by mixing and chewing with saliva. After that, the muscles of jaw and oral cavity will start to propagate the food into the other part, down part of the area. The solids are chewed, mixed with saliva, made into apparent-sized bolus. Solids, anyhow, you know the bolus, but don't think the liquid will simply pass like a fluid in other areas. It is also formed into a bolus. It is poured and sucked into, and it is maintained as a bolus. Liquid also passes as a bolus in the oesophagus. The jaw is closed by jaw elevator muscles, that is temporalis muscle, masseter, and medial pterygoids. The jaw is closed by jaw elevator muscles first. Lips maintain seal under the action of orbicularis oris. See, you are having a orbicular oris. When you close the orbicular oris, the lips are totally, oral cavity is sealed. Then the food is returned from the vestibule of the oral cavity by contraction of the buccinators. The buccinator cheek muscles, they contract and the food is pushed to the center part of the oral cavity. Throughout this phase, the soft palate is lowered. You are having a soft palate is lowered and anterior posterior pilus approximated under the action of palatoglossus and palatopharyngeus muscle. That is anterior and posterior pillars of the tonsillar fossa. They come together, soft palate is lowered, the oral cavity is sealed posteriorly, and the airway only remains open. The bolus is progressively accumulated on the posterior surface of the tongue by several cycles of upward and downward movement on the tongue surface. This bolus slowly passes to the posterior surface. When the bolus consistency sensed by the mechanoreceptors in the oral cavity, which is suitable for swallowing, the oral phase proper begins from this area. This is all preparatory phase. Later, proper oral phase starts here. See, from this, there is formation of the bolus touches the superior surface and particularly posterior one side. This is oral phase proper. The masticated bolus is placed on the dorsum of the tongue behind the tip. The dorsum makes a longitudinal groove by contraction of the smooth lingual muscles and also the genius muscles. Then the heaped up tip and margins are in contact with the hard palate. The elevated tip margins are contact with the hard palate and the teeth. The bolus is imprisoned in the groove over the dorsum of the tongue. Then the mylohyoid muscle starts contract, raises the floor of the mouth, compressing tongue against the hard palate. This mylohyoid contraction. This will create a pressure created obliterates the groove from before backwards, pushing the bolus into the oropharynx. When mylohyoid contracts, it raises the floor of the mouth, then pressure is created, obliterates the groove from before backwards, pushing the bolus into the oropharynx. The compression of the mylohyoid muscle on closed oral cavity pushes back the base of tongue like an arch of circle with hyoid at the center. This propels the bolus with considerable force into the pharynx. Slowly this bolus enters into the pharynx. The pressure about 20 centimeters waters are developed in the posterior part of the mouth and pharynx and upper part of the oesophagus by contraction of the mylohyoid muscle. 20 centimeters of the water pressure is created by the mylohyoid muscle, which forces the bolus into the pharynx. This is how you are seeing here. Food is formed here. This mylohyoid contraction pushes it posteriorly slowly and it enters into the pharyngeal space now. What is the pharyngeal space? Once the bolus passes palatoglossus and palatopharyngeus, then the swallowing becomes reflexive. I told you, when the esophageal, it is totally involuntary, but pharyngeal, it is both voluntary and voluntary. There is a mix, it is a reflex process. As the bolus is moved back by the tongue to enter into the pharyngeal sequences of events, which is initiated ensuring the protection of the airway. Here, the pharyngeal part, the main important thing is you have to protect the bolus not to enter into the airway. How the protection is created is, first one is the diaphragmatic contraction is inhibited by making simultaneous breathing and swallowing impossible. See, the diaphragmatic contraction stops what you call ingestion apnea, that is a small cessation of the breathing will occur. At the same time, there is a closure of the nasopharyngeal isthmus. Soft palate is elevated to ensure the closure of the nasopharynx. Diaphragm is paralyzed or contraction is stopped, and the nasopharynx is closed by elevating the soft palate, particularly at the area of Oesphagus ridge. You know the Oesphagus ridge in the soft palate. Finally, as the bolus is moved into the oropharynx, a reflex closure of the glottis is initiated. That is how the vocal cords start to close to protect the airway. How the larynx is closed by contraction of the muscles of the laryngeal inlet, that is enteroretinoids, aryepiglottic folds, and thyroepiglottic, these muscles, thyroepiglottic fold, enteroretinoid muscles, and thyroepiglottic muscles, they contract and close the larynx. But what do you call, it is a resembling of a drawstring purse purse is closed at the level of the laryngeal inlet. The larynx is closed under the contraction of the supraoid muscles in order to narrow the laryngeal inlet, moving it toward the pharyngeal surface of the epiglottis, elevating the larynx. The larynx is elevated, then the reflex closure of the glottis is initiated by apnea, what we have discussed earlier. When the bolus enters the oropharynx, it is widened due to relaxation of the pharyngeal constrictors and partly due to anterior movement of the pharynx. As the hyoid bone is drawn forwards under action of suprahyoid muscles. As the foot passes over the posterior part of the epiglottis, it is diverted into the piriform fossa. Solid part of the foot tends to go straight over the epiglottis, whereas liquids are diverted laterally into the piriform fossa. From piriform fossa, they enter into the cricopharyngeal area. The simultaneous relaxation of the cricopharyngeal sphincter allows the bolus to pass from the pharynx to the oesophagus. The pharynx constricts behind the bolus as the superior constrictor muscle starts. Pharynx constricts behind the bolus as the superior constrictor muscle contracts. Then the oesophageal space, the cricopharyngeus muscle relaxes up, which leads to the upper oesophageal sphincter opening. Bolus is passed through the sphincter and the oesophagus by peristaltic movement. The tensor and levator palatine muscles relax, lowering the soft palate, laryngeal inlet, and vestibular opening to open by hyoid and open, and this hyoid and larynx drops once again into the normal position at the very end stage of swallowing, and the glottis is open. See again from here it enters into the peristaltic movement. This peristaltic movement goes up to the diaphragm, then the bolus enter into the stomach. The primary esophageal peristaltic wave is nothing but a pressure rises slowly to 50 millimeters. 50 millimeters of water and falls rapidly. The sequential continuous movement of the circular muscles of the oesophagus result in contractile wave which migrates toward the stomach. Bolus slowly reaches to the lower esophageal sphincter. It relaxes and opens the bolus into the stomach. Later, the secondary peristaltic wave, which arises locally in response to the distension needed for more solid bolus transport. There are different peristaltic waves. Primary esophageal peristaltic waves are, it is a pressure raised slowly 50 millimeters and falls rapidly. Sequential contraction of circular muscles of the esophagus result in contractile wave which migrates toward the stomach. The bolus reaches the lower esophageal sphincter. Secondary peristaltic wave in response to distension, which is needed in weak solid bolus transportation. The tertiary esophageal contractions are irregular, non-propulsive, involving the long segment of the esophagus. The 3 centimeter long lower esophageal sphincter behaves like upper esophageal sphincter, but with lower tonic contraction pressure, that is 15 to 25. There it is 60 millimeter, relatively low in intragastric pressure. it remains closed except for relaxation when bolus and peristaltic waves are bolus moves when peristaltic wave arrives. The barrier formed by the lower esophageal sphincter, tonic pressure is lower after meals and tighter at night. Lower esophageal sphincter, the tonic pressure is lower after meals. After meals it is lower, but it should be very tight in the night. If it is loose, the possibility of GERD will arise in this particular part. Three main forces moving the bolus in a coordinated manner, independent from gravity, are tongue thrust pushing force, pull of relatively lower pressure in the oesophagus, as the upper esophageal sphincter opens, termed as hypophageal suction pump, the downward pharyngeal contraction movement for pushing the bolus tail there. The neural controls of swallowing, they involve a number of different regions of the central nervous system, extending from the motor nuclei with brainstem up to the cortex. The act of swallowing is regarded by sensory feedback. It is regulated by sensory feedback. The initiation of swallowing either be as a voluntary act or reflex as a result of stimulation of the mucosa in the oral cavity. The latter may occur during saliva accumulation or by presence of the food or liquid in the oral cavity. Due to anatomical physiological close relationship between swallowing, ventilation, mastication, there is extensive overlap in the brainstem areas controlling these areas. The voluntary initiation of the swallowing involves bilateral areas of frontal, prefrontal, parietal cortex. The frontal swallowing center is associated with motor control of the swallowing. The centers, which includes are lower precentral, posterior, inferior frontal gyri, that is in the oral phase, middle frontal and anterior inferior frontal gyri in the pharyngeal and esophageal part of the deglutition. Descending pathways project from the frontal swallowing areas of the cortex to medullary swallowing centers within the medulla. There are a number of nucleus in the medulla involved in the process of swallowing. The nuclei receiving afferent input is nucleus tractus solitarius, spinal trigeminal nucleus. The efferent pathways from the medulla pons to the swallowing muscles include nucleus ambiguus for muscles of palate and pharynx and the larynx, motor nuclei of the hypoglossal nerve for the tongue, motor nuclei of trigeminal for the jaw muscles, motor nuclear facial, that is lips, that particular orbicular circle. The swallow reflex is a complex neurological event involving the participation of high cortical centers, brainstem centers such as the tract of the nucleus solitarius and the nucleus ambiguus, and the cranial nerves 5, 7, 9, 10, and 12. Coming to the cranial nerve 5 and 12, they take part in the chewing and tongue movements, and particularly the 7 nerve sensation of the oral cavity, anterior 2/3 of the tongue area, and motor supply to the orbicular socket, oris, is oral muscle. And 11 taste of posterior tongue, sensory and motor functions of the pharynx. 10th nerve, taste of the oropharynx, sensation and motor function of the larynx, laryngopharynx, and also the airway protection. Neurological deficit in any of these areas can result in dysphagia. This is what centers will take part. In most people, swallowing control is asymmetrical with projection from one hemisphere being larger than the other, independent of handedness. Right-handed people, the left, that is how it is dominant. Also, other cortical structures like frontal operculum, insula, and orbitofrontal cortex are implicated in swallowing. Cortical structures are not essential for coordinated swallow movement. See, these are some pictures where you are seeing the barium swallows. This is a part of the pharyngeal phase. From there, it enters into the what you call esophageal phase, thoracic phase. Then from thoracic, it enters into the cardiac part. This is the stomach where barium is filled out, coming out. This is the particular area where you are seeing the diaphragm. From there, it enters into the stomach, cardiac end. Right. Thank you.